Good evening, everyone. We'll still wait for a couple of minutes for people to assemble. So we'll wait another 5 minutes. Some people will be following the session through Facebook Live and some through Zoom. So let's just give people a couple of minutes more. Hey, Christos, there you are. We thought we lost you. Okay. We'll just wait for 3 minutes more before Valeria takes the word, and after her, it will be Pantxo presenting first, and then you, and the two of you will then take questions in the end.
Okay, cool.
Good evening, everyone. We've now waited for 5 minutes. I guess most of the people planning to join the session are already here. So first, I wish to welcome you on behalf of Pilot Care Crew. Currently in Zagreb, we have an exhibition on display within which we are organizing this 2-day seminar today with Pantxo Ramas and Christos Giovanopoulos, tomorrow with Sanja Horotinčić and Madalena Franito. In a way, the exhibition in Zagreb is the concluding event of our 4-year-long research. Maybe Valeria will say a couple of more words on this endeavor. But with this, we are trying to kind of go full round and present some of the practices that were inspirational for us and that have shaped the notion of pirate care over these 3.5-4 years that we've been dealing with the subject. Okay, so maybe I hand over to Valeria. I will just ask you kindly to keep your microphones muted, and there will be a chance after the end of both presentations and Valeria's introduction to pose questions. You can pose them either here in the chat or on Facebook, or if circumstances allow, you can open your microphone in the end. Okay, so handing it over to you, Valeria.
Okay, so thank you, Tommy. Thank you, everyone, to be with us for this conversation. I'm Valeria Graziano. I'm one of the facilitators, coordinators of a much broader group of practitioners that have been transitating through and feeding and contributing these 4 years of research and practice that is pirate care, and that we are here kind of wrapping up and trying to carry forward in other ways, shapes, and forms. I will say a few words to contextualize our conversation, but I don't want to take too much time because I think that we have an opportunity, I hope, to really get into some discussion, and let's take maybe some advantage from this, the intimacy of the screen somehow, to really try to make a point and think together. I, for one, feel that there is a lot of need to have collective public discussions around health and healthcare. Both of these things are very difficult terms to define in our present juncture, I think. Pirate care started in 2018 as an idea, and then we started in 2019, and it is a pre-pandemic project. Indeed, we started a bit earlier than, and I'm not implying by this, sorry, that we are in a post-pandemic moment at all, as we know. I think it's very clear, but some conversations are starting to assume that in a peculiar way. Anyhow, we started a bit earlier, and when this pandemic started, we already have been working at the time with about a dozen or 15 or so between activists, scholars, and artists, whom in one way or another spoke to us around this concept of pirate care, which in very short and broadly we perceived as being a new kind, maybe to describe a new kind of militancy or activism, if you like. So on the one hand, people getting criminalized because they would volunteer to bring aid to groups of or kind of sections of our society that are the most vulnerable, marginalized. And we really saw in the 2010s a proliferation in a number of states of legislation criminalizing acts of solidarity that would transgress basically the border regime, which is everywhere in our society, that would transgress ideological positioning around reproductive right or the so-called gender ideology wars, and so forth and so on. So we started at the time to document a little bit what was going on. And many of these practices are now in the exhibition space in Zagreb as little stories that I hope some of you will be able to visit. And they will also be documented online. And in order to share what we were learning, because we really think that there is a lot to learn from these disobedient practices of care. So our project is basically a media object and it lives online as a syllabus, which is the English name for some kind of curriculum or like material that can be used hopefully to learn together in various configurations and think a little bit about the state of affairs of really where we're at in societies at large in supporting and articulating the capacity of care that we have. There are many definitions of care. I think it has become a very used and abused term in the last years that coincided with our project. So in our reflections, when we are amongst ourselves, we often start to really to say, oh, enough with care. No, like it's such a great term because of this capacity to carry together a form of labor, but also ethical implications, but also, of course, materialist implications about the tools and the resources, the infrastructures that are needed. But at the same time, this elasticity maybe also makes it a concept that constantly needs reworking. So I'm also very curious to hear from our speakers tonight what is their take on that. And in terms of the piracy situation, aside from this criminalization problem that I was kind of thinking about, we were thinking about at the beginning, there is also a parallel question that is very present for us, and that has to do with the property regimes that are in place and that we often don't perhaps discuss or don't perceive as much when thinking about care practices. And because usually care is discussed in terms of labor, right? So hopefully it should be. I hope that people in these rooms will come from these conversations that recognizes a lot of this labor is informal, it's performed in all kinds of informal arrangements within the family, kinship structures, but also in so-called Black economy. And to put it like David Graeber, it's often the case that the ones who perform the most of this care labor are the ones that most unlikely to receive care in return, right? So, but yeah, so aside of conceiving care in relation to problems of labor regimes, for us, piracy was also a way to point to the problem with property regimes. And one of these, the biggest questions in our time, even now, as we speak, is the question of who controls the patents for vaccines. But this is the top of the iceberg, really. This has been one of the property regimes that now it has been picked up by media a little bit. And of course, there are so many other questions that could be asked around who owns our tools for caring, our knowledges for caring, who has access to those and under which conditions. We're very happy that WWII invited us to present our last survey exhibition in Galleria Nova. At this time, and also with the support of Mama, of course. So we're very grateful to both of this amazing collective of people. Also because we are living in a moment when, yeah, we might want to rediscuss the terms of healthcare. So without further ado, and maybe with just this little survey to break the ice, I hope, I will introduce you briefly both Pantxo Ramas and Christos Giovanopoulos. who will be going deeper in a few of these questions relating to very specific situated practices. So Pantxo Ramas, who will start, is joining us from Trieste, and he has an academic background in social sciences, political economy, and urban studies. And after many years of being an active participant in European and Latin American social movements, and he also had some background as a public policy consultant, he landed in Trieste with, and he became the coordinator of the a documentation and research center that is hosted by La Collina, which is a social cooperative, in collaboration with Coopersam, that is the permanent conference on mental health in the world, Franco Basaglia. And this is also in conjunction with the Department of Mental Health of the city of Trieste. And Pantxo in his talk is gonna take us through some considerations of the legacy of the Basaglian radical reform, of radical approach to psychiatry, which for those of you who might not be familiar with this legacy, made it so that Italy is one of, if not the first country, but I think it is the first country to abolish formally in its legislation the asylum as a total institution for dealing with different conditions of mental health. And after Pantxo, Christos Giovanopoulos, who is an Infrademos project researcher, joining us from the Netherlands, but I'm not sure anymore where to place you, Christos.
No, actually I'm in Athens now.
Okay, great. So we have a southern transversal conversation, great. So Christos is based in the Department of Social and Cultural Anthropology of the WWII Universiteit in Amsterdam. And he also has a lot of experience as a grassroots solidarity activist with the solidarity movement in Greece. And he will address the experience of the solidarity clinics and pharmacies that have developed in Greece since the 2011 kind of benchmark year of political organizing in response of the crisis. I think these two talks will have a lot in common, so I really do hope that after we spend maybe 20 minutes with each of you, we can maybe really open up the space for some conversations and comments and bounce back and forth. Okay, so over to you, Pantxo.
Thank you, Valeria, and thank you, Tommy, for the invitation and in general for the project. I think that Parrot Care has been a project that really gives us a space to reflect with and to think through the practice of care and through the possibilities of invention and disobedience in a sense. And you were asking me to explain, to look through the practice of disobedience here in Trieste. And maybe I will start from trying to equate a bit the context in which we are. I am working, and in which I want you to fall into. It's a bit strange because now I'm talking about in front of a number of names. I don't see any face, and so I'm kind of unconnected. But what is the space of Trieste is very interesting to me, and I don't know. I need faces to understand if I'm making some sense, and not to control what you're doing, of course. But so in the space of the context of Trieste is an interesting context, I think, because as Valeria was saying before, it is the first place in Europe where an asylum has been closed, has been opened and then closed down. It was in the 70s, and it was on the wave of a longer transformation in mental health care and the critique of psychiatry, which you might know because of Laborde and France, for those of you that like Guattari and Deleuze, from Lying and Cooper, for those of you that have a more Anglo-Saxon background, but in general from that wave that in the 50s, in the 40s, in the 50s, and in the 60s started to dismantle the concept and that institution that is madness, no? Rotelli once wrote, we are not dealing with the institution as the asylum. The institution we are fighting with is the way in which madness has been constructed. And in Trieste, it was in 71 when Basaglia arrived, and it was in 71 when this process started. And I think there is two elements that might be interesting to stress before I give you a short sketch of a timeline and of phases of the story. One is that in Italy, there is no more psychiatric hospitals, which is a very significant thing. It's not just there are no more asylums as total institution, but there is no more monovalent structures. The most of the countries in the world, we were talking with Tommy a few weeks ago about the situation in Zagreb, no? You have hospitals that are exclusively dedicated to mental health and psychiatry. And this is the case all over the world, I would say, apart from England and Italy. In England and in Italy, the mental health care structure are part of a general hospital, or in Trieste especially, are completely dedicated on the territory. So there is this element of non-monovalent structures. And then there is what has been very important, I think, in Trieste, that is not to build alternative practice of care, but substitutive, if you can understand that, if I can, it makes sense the term to you, which is the fact that the practice of mental health in the territory has not been an alternative to a psychiatric hospital that was still there, but was a substitution of that system with another system. So where this starts from, I have a few maps behind me, and I tend to hide my self-view because I don't want to see myself when I speak, but otherwise I can. So the first map you see there, the first one, this one, is the way in which the hospital was organized in the early 20th century. This hospital, where I'm staying right now, was a hospital built during the Austro-Hungarian Empire, and the idea was to produce a space of calmness and tranquility for those that were mad. So the logic of it was really the concentration camp, but luxury concentration camp. So to close everybody that was different in the space of the asylum, and to provide here for a calm and disciplined life. And obviously this led to violence and segregation. It was also 1908 when this started, and so you can imagine that in 1915 the First World War started here in Trieste was particularly strong, and the connection between psychiatry, war, and Nazi-fascismo, Nazi fascism was very strong. The idea of eugenetic idea of a normal and abnormal person was the idea of organizing the people in the asylum, as it was also the idea of concentrating difference in the concentrating camp, etc., etc., etc. So this is important because when Basaglia arrives here in 1971, he comes, and his keeps comes from the understanding of the need of reorganizing the asylum and reorganizing psychiatric care, mental health care in a way that wasn't coercive, as it was the case in Lying and in Cooper and in France and so on. But especially they come from an idea of keep on with an anti-fascist struggle, and so to give back to the people all their full rights of citizenship. Anti-fascist struggle was the struggle of reorganizing the practice of care. And I think Christos will tell us that also in Greece, this was a case in the last 10 years. So to think that the practice of care are fundamental in order to think another way of caring, but especially of denying a certain role of institution in organizing social life. So if the first is the total institution, as Goffman named it, the second one, the one that you can see here, is what Basaglian named as the denied institution, the practice of denying the organization of the institution, and by that practice of inventing other and new forms of organization. To make you it in a very clear and plastic sense, the asylum, as in the map that you see in the first place, were organized by gender. The pavilions were organized by gender on the left and on the right, and by dangerousness. So going top of the hill, you would go to more and more dangerous people, more and more constrained people. The way in which Basaglia and his equipe reorganized the asylum early in the 70s is by neighborhood. They go out of the diagnosis and they start to organize what is the social life, the complexity of social life, each of the people that has been detained here for 50 or 60 years is, and how we reorganize a practice of care that tries to reorganize the pavilion by neighborhood, and by that connect the pavilions with the city, with the neighborhood, with their life in the neighborhood. And in order to do this, they buy cars. They buy 5 cars, which are called the green ones, and they start to move to reorganize the patients in the asylum by pavilion, by neighborhood instead of dangerousness, and they start to find what is the kind of life that there is in the city. And the need is that of inventing a practice of care in the city, which is Center for Mental Health Care that are open 24 hours a day. That means social cooperatives that organize labor. That means laboratories of artistic production that are connected with the arts networks of the city. And then also to think that, and this would be the third map that is behind me, but also to think that this story is connected with, is not just true for mental health care, but must be true also for care in general, that practice of care, and again, what Christos will tell us later is probably very connected to this, must be in the complexity of life. It doesn't make any sense to tell to somebody that is, I was reading today Bertolt Brecht, he was saying this in the 30s, was quite amazing. But you cannot say to somebody that if he has diabetes, must have a good food culture and walk if he's unemployed, depressed, and he lives on the 6th floor of in a periphery without a lift. So to think care means to think through the problem and the problematicity and the difficulties of social life in general. So, but I was telling you that Tommy and Valeria were asking me to talk about, and so this is the format, just to say, the moment in which here in Trieste, the system of care that was in the asylum starts to be distributed in the city. And these 40 dots are the pieces of care that are now in the city. But,
excuse me, Pantxo, can you maybe bring your computer for a second closer to the map so that people can actually see the map?
So this is the old map of how the asylum was organized by gender and by dangerousness. So agitated people, semi-agitated, dirty people, which was people that couldn't hold their liquids. And then on the top of the hill, the city of labor, where people was working by free, because again, here the connection with Nazism is very clear, because work is therapeutical, or work makes you free, no? And And then in the 1840, this is 1847 was a fanzine that was in the asylum, and this was a mural fanzine in which they were explaining how they were closing pavilions, and I was telling you they were reorganizing it by neighborhoods. And this was done by a very great artist, Ugo Guarino, and who built serigraphy and started to produce an internal newspaper for the asylum and make it as a tool of discussion on what was the transformation. There are stuff on sheet and food which are amazing. This is in the already in 80s, late 80s, early 90s, the way in which the asylum started to become, the closed asylum, the asylum was closed in 77, started to become a space of counterculture in the city. You can see also the style of the map is very interesting, and you can have like here you have laboratories of arts, there you have the radio where that is now here, and all the organization of a system of circuits and electric electroshock, but on the other towards the city. And the last one is always by Antonio Villas, which is the designer of the first one, the way in which the system of territorial care, especially mental health care, has been reorganized in the city. And so you can see mental health care center, residencies, the district, drug addiction, and so on. So in a sense, what I wanted to start to try to talk quickly about is the matter of disobedience, because Valeria was asking me and told me to talk through to what is the role of disobedience in all this. And I think that here the level of disobedience is very interesting, because it's in my understanding a very anti-heroic practice. It's never the idea of a disobedience that destroys the system, but it's a disobedience that try to find a way in which you can dismantle piece by piece the system and reinvent something that supports people that is in pain, in suffering. I really like this this comic by Ugo Guarino again, that I think makes very clear what was the case in the asylum in that moment. It's called spettinata. You would translate spettinata, Valeria, help me please. Like
scruffy, in Italian it's uncombed, when your hair are like mine, pretty much. But, or Pantxo.
She was one of the symbols of the Trieste mobilization, because the idea was not just to claim what is your rights, but also to understand how to deal with it, how to claim it back, how to reappropriate it, and so on. So she starts by saying, I'm uncombed, I would like to comb. In order to comb, I need a comb. I need a comb. I don't have a comb. I want a comb. So the idea was that of building this practice of disobedience as a collective practice, as a practice of collective emancipation. It's very interesting and I will make you 3 short examples of this disobedience through the years. The first is the opening of the mental health centers. We're talking about 1976. So years in which there are a lot of social mobilization in Italy. And the most of the public services that are now for mental health care here in Trieste were squatted in the 70s, were squatted by doctors, which took them, opened them, and opened the negotiation with the local authorities in order to have them recognized as part of the mental health care system. There was not a capacity of building formally an institution and then producing it practically. The game was always the other way around. You would occupy a place, you would organize a certain kind of system and way of organizing care, and then you would call the authority to recognize that as a system that needed to be supported and recognized and economically supported, and that was useful to what was the practice of care in the difficulties of social life. Again, something that Christos will tell us again about. So what is interesting to me in this is that there is a molar relationship to the infrastructure of the state. Is the invention not only of new relationship of disobedience of a social movement that from outside say something, is the production of pieces of that infrastructure, and then the need of finding a negotiation with the state, because that piece of infrastructure is necessary for the development of the maintenance of a certain level of health, which is necessary to all the society. The second level of disobedience I want to talk about is the social cooperatives. The social cooperatives are a way of organizing that starts in the early 80s, actually in the early 70s here. The first one is organized in 72. Just 1 year after Basaglian arrives in Trieste, they organize a cooperative. Why? Because people is working in the asylum for free, in that little city of labor that I was showing you before, under the slogan that labor is therapeutical. After a few months, on the walls of San Giovanni, there is a new slogan that says, freedom is therapeutical, and therefore the need of building a cooperative is the only way to recognize to the workers the fact that they are working, the fact that they have social rights and political rights, the fact that they will have a salary. When you would enter in the former asylum, you would lose forever your social and political rights after 1 month of being interned in the asylum. The possibility of inventing the cooperative of Posto delle Fragole in the early 70s gives back formally the social and political rights to the people that was inmate in the asylum, and is a practice of disobedience because the form cooperative didn't exist yet. Actually, the foundation of the cooperative, the first contract that the cooperative gets is before the constitution of the cooperative. So the invention of the practice is before the moment in which it's formalized. But this invention allows, I think, two things that are very important, and that you can see in this map. The fact that the same map you see in the beginning, this very formal and aristocratic map of a place, a beautiful place of care, where the crazy ones can be finally calm and serene because they are cared for by the Austro-Hungarian Empire, is transformed in a countercultural space where there are raves, where there are parties, where there is radios, where there is laboratories of arts. So the occupation of the space, the transformation of the sense of the space is fundamental, not only to produce a difference in the life of those that were interned, but in order to produce new alliances that break the closed logic of psychiatry. And let me get back to one point I was mentioning in the beginning. Franco Rotelli was saying what we are destituting, what we are destroying is not the institution of the asylum, it's the institution of madness. What does it mean? The fact that there is an idea of madness as something separated, completely excluded from society. And this is the game of psychiatry all the time, of psychiatry, psychoanalysis, and all the the fact that that stands on the sofa or in the asylum, but always in a separate space, in the family, in the madness, in the diagnosis. The idea in Trieste was really to open and break this autonomy of this circle. There's autonomy of the political, and put it in the social. And so here you would have the counterculture, the social centers, the radical arts, intertwining with people that was in sufferance, but that was finding a new way of connecting with life in the second place. So I think this is the second practice of disobedience I wanted to stress. The first is the one around the organization, the moral organization of the state. The second is the one about the molecular construction of madness as something separate and out of society. And the third disobedience I want to briefly mention is the one about the rose garden here in Trieste. Here in Trieste, there is a rose garden that has been built where first there were the vegetable gardens that were organized by the free labor of the asylum in order to provide food for the people living in the asylum itself. So in the early 2000s, Franco Rotelli and the equipe that was managing the asylum in the mental health care system in the 2000s decided to transform that vegetable gardens into a rose gardens and to put the difference and the diversity of roses as a symbolic and material cipher of diversity and of beautiness there was only uniformity and violence and horror. And I like the fact that they did it disobeying to what Franco Basaglia has said in the 70s. Basaglia died very young in 1980s, and I think it's important to stress how this story was done by those that were without a father. The death of the father was very important. The death of the father was very important to avoid a number of problems of leadership and so on. But Basaglia said, what we have to do is to destroy this place and to do nothing more than go out of it and leave this space behind us. And in the 90s, after the countercultures reoccupied this place and give another sense to this place, there was the necessity from the people that was living here to give another sense to the same place. And I think this third disobedience is the disobedience against ourselves, the fact that we have to disobey to our own ideologies, the fact that we have to think that we can think something in a moment and think that's something useful, that's something necessary, but then we have to be enabled also to disobey to ourselves, to think through and through what we have been doing and trying, and recognize that at a certain point it's necessary to go back to that and think another time to what to do. 2 minutes and I close. The first minute is to say that Franco Basaglia was calling it a deviant majority. The most of the people is deviant from normalcy, and nonetheless they look like a minority, but the deviancy is the majority. And I think that disobedience is the quotidian, the everyday affirmation of this deviancy, but is a gradient. We just need to deviate a little bit what is needed and what we are capable of. So deviancy and disobedience as a gradient, as a single but quotidian practice. And just to make you an example, we are now trying to produce a map of like this one, but in a living form. So we are trying to get all the plants from each of those spots on the map. We are trying to get some small plants, no? To make a living map in the archive, because we don't want the archive to be a place about documents of the past, which we have 30,000, but we also want to have living objects of what is the system now. And so we have decided to make a living archive of all the plants that workers and users bring to the different spots of the social services of mental health here in Trieste. And we are going around asking for these plants. And 2 days ago, we went to ask to in one of these services, which should be and are actually radical practice of mental health care, deinstitutionalization, against institutionalization. And one guy told us that if we want a little bit of a plant, to plant it in a new vase, una talea, I don't know how you say it in English, like a cut of a plant that you replant, we should write a project and ask for the permission of the general director of the regional healthcare services. And we thought it was very interesting to see how the practice of disciplining any a very small gradient of disobedience that we are doing, that was stealing a plant, is always something that can be disturbing. And so it was for me interesting to close with this, because it gives you a sense of how the practice of Trieste has been a radical practice every day since 50 years, but yet the practice of institutionalization, of disciplining, and of closing down imagination are still very present. Then I have a few things that I want to say later, but I think that I will let it to Christos, and probably something I will be able to say later.
Okay, thank you, Pantxo. This is really amazing. You touched upon so many interlocking dimensions of ingredients of disobedience and instituting practices. I will now pass it over to Christos without further ado, so then we can indeed enjoy some time at the end all together and bring these stories in resonance with each other. Welcome, Christos, with us from Athens.
Hi from me also, and thank you for the chance to meet all the faces that I haven't seen in a while. Yeah, so the first thing I want to say is that the disobedience that is included in what I will describe of the experience of the Solidarity clinics in Greece, as you can see, it was not the aim from the beginning. Neither it was to develop alternative forms of healthcare. The starting point was different, but it included both elements, and also it included much more. Because I believe that the experience of the Solidarity movement in Greece the last 10 years has got very strong prefigurative elements and qualities that were overshadowed while it was happening, while it was in its peak, because of the major political conflict at the time around the Troika regime and countering the effects of the austerity. But all those were interweaved together. So let me share my screen. Yeah. Okay, sorry. Can you see it now? Yeah, okay, cool. So I will, part of what I'm doing now, it is actually to reflect on this experience as a form of popular infrastructuring, popular social infrastructuring. What kind of infrastructures this grassroots solidarity movement has created. And I will focus today in the Solidarity clinics, and even more than that in the Solidarity pharmacies as a practice of commoning. But I want to start from giving the framework within which the content within which those emerged. So the grassroots solidarity movement started just after a couple of months after the squares occupation movement, and it was a result, an offspring, let's say, of the experience of the squares occupation of the Greek indignados. Yeah, the important contribution of this movement that it was that made tangible, and to the Greek people, the practices of self-organization and direct participatory democracy. And also, it is important not to forget this initial moment, exactly because it gives the political context and the political motive that informed the development of the solidarity crisis and the countering of the solidarity structures and the countering of the effects of the austerity. Okay, so it was not just an anti-austerity discourse. It was not just an anti-crisis or within the crisis discourse, but was also a discourse about the people's sovereignty to decide about democracy and all that. And this is important because it has informed also of independence from the state and party politics and representational politics, because those elements were informed the concrete practices that followed by the solidarity structures and the solidarity clinics. So in in September 2012, there were already 200 solidarity structures around, and 400, and in almost 2 years, this number was doubled around Greece. And here you can see a map of the greater area of Athens, the metropolitan area of Athens, and you can see only 3 out of the many other kind of fields of solidarity practices that were developed at the time. As you see, there are many solidarity clinics and pharmacies already developed in 2014. In Athens, there were around 20. 16 of those participated. They had their own network. Okay, so more specifically regarding the health, the context in the health provision, in 2000, between 2012 and 2014, let's say more or less in the peak, over 3 million people lost the right to access to the public healthcare system. Yeah, this includes unemployed people, because having social insurance in Greece is connected with your employment status, and also includes refugees and immigrant communities. And in the meantime, we had 45 social solidarity clinics and pharmacies around the country, providing free primary health care to those excluded. And just to give you a sense of the volumes of volunteering and how many people were engaged in this kind of operations, there were 16. Maybe I didn't. Did you see it full screen? No, yeah. Let me do it full screen. Okay, maybe now it's better. So you have 16 solidarity clinics and pharmacies, and 750 doctors, 2,000 appointments per month, which is not something. Next. Okay. So, yeah. So let's see now some of the principles of around which those solidarity clinics and pharmacies were operated. First of all, this is from their own chart issued in 2013. First of all, as I said, they're autonomous, independent, self-organized collectives, which they later, you will see from where they're autonomous and independent. They operate in a direct democracy way that secures participation on an equal basis for everyone, employed and uninsured, but also doctors and not doctors, medical and not medical specialists in the organizing of the clinics. So this is the first opening of a usual kind of healthcare institution. And they identify themselves as structures of struggle and resistance. So the issue is not, the transformation at that time is not there, the prefigurative element of them, but also the struggle and resistance. It is not related only to the healthcare issue, but to the larger situation. And they rely on people's solidarity, which they say that they accept only donations in kind. So they try to minimize as much as it gets, the use of money and funds. They don't publicize any donors, and they're independent from the political parties. So this is just some of the. This is the two graphics there. On one, you see how the Metropolitan Clinic of Elliniko presented its own kind of structure of decision making. Sorry. Yeah. So you have the red circle is the volunteers of the MIKIE, and the blue circle, it is the assembly of the volunteers, and the smaller cycles, are the the working groups and the assemblies of the working groups, with this one on the top, which actually should have been on the top of the center and connected with all the rest. It is the cooperating group of all the all the working groups. Yeah. So they try to in 2 dimensions to put a kind of a multi-layered kind of a scheme. So what is also where they also independent from this solidarity clinics, it is autonomous from as I said, from political parties, also from the state and the markets, because they don't accept any money from those, and they are informal organizations. Out of 56, but these 56 does not include only self-organized solidarity structures, but includes also some from NGOs or the church, etc. But you see that it is from another research made in published in 2015. So it was made in the same period. 52 out of the 56 social solidarity clinics, they were informal, yeah, without any legal status, and this was a political choice at the time. So here it starts the issue of disobedience, let's say, because one of the first conflicts that they faced, it was the pressure from the government and also from the Union of Doctors in Greece, that they are not allowed. It is very dangerous, and they don't have the rights to provide healthcare services because of that. But also, it is the volumes of the degree, the volumes of the crisis, and also the number of people who participated there, and the acceptance that they had in the society. They gave them the political strength and the legitimization, you know, to carry on what they carried on, and to demand from the municipal authorities buildings. Okay, we have a diverse regime of premises and buildings. Many of those, the majority actually, they are hosted in idle municipal buildings that they asked to do this operation, and they were given to in that circumstances. Some they have rented spaces, and some other less. 2 or 3 they have they are in occupied spaces, yeah, and some they are also in trade union space, 1 or 2 provided by trade unions. Okay, so another issue that kind of very ambivalent issue, let's say, and challenging issue, was their relations with the public healthcare system, not with the state itself, but with the public healthcare. Okay, so in their declaration, what they say really it is that they don't want to substitute the state and the public healthcare, the state's responsibility and the public healthcare system, but at the same time they will not leave people without protection. And so this is why they don't do charity, but they fight collectively to reinstate the public health care. So this was a very good and pragmatic at the time, in order to show that if you want really to have public health care, you can do it in other ways, in a different way, and provide it. But at the same time, as we see later, after 2016, when the access to public health care was reintroduced, it shortened the view of the perspective of solidarity health care of the future. So again, the issue of access to public health care, it overshadowed the transformative elements that they were born within this practice. So how they were organized? They were organized in in a national level through coordination meetings. In Attica, it operated until 2017 or something like that, a coordination group. They did joint actions and campaigns with public hospital workers. Yeah. Also, they participated in regional networks of solidarity structures. Yeah. And they had also connections with solidarity campaigns or other similar groups abroad. So you have many different scales within which, you know, the solidarity clinics operated, and this is important in the different ways that that people start to create their own networks and pool resources or exchange skills and understand, you know, what the healthcare infrastructure is, let's say. Now, in 2015, it was a kind of a very critical moment that challenged what those solidarity clinics were building. I will tell later about, if you're interested, about all how they affected, you know, the health care provision, you know, and practice, you know, medical practice. I will tell a bit later. So the problem was in 2015, it was we had two different kind of they coincided, but there were two moments. One was series as U-turn and the disillusion that brought in, and the other one was the solidarity with the refugees movement, that it brings new life, you know, a new purpose to the solidarity clinics. Actually, the first solidarity clinic was created just 2, 3 years before the crisis started, and was in Rethymno in Crete to meet the needs of undocumented immigrants and refugees. And this practice was taken after. Yeah. So the element of being open to everyone and not only to citizens, it is very important in the actual life of the kind of organization of the solidarity clinics. And then in March 2016, the re-establishment of the free access to public healthcare system, excluding the refugees and immigrants, it meant that the doctors, it meant that the solidarity clinics, they changed the policy, and because they saw that their main demand for open access to public healthcare system was met, so they started directing the patients that were going to them towards, you know, the public healthcare system again. Okay, so it's a big. There are other complications because the public healthcare system opened again the gay access, but with less funds and less people, etc. So we have other kinds of problems created there that we live now, and we see the very bad state in the pandemic in Greece. Yeah, but at the same time, they stayed loyal to that. They didn't want to substitute the healthcare system. But as the reality showed, you know, they couldn't stop functioning because there were a big part of the Greek society that still needed them, and something especially because of the cuts in medical support and medical funds. So and therefore they changed their direction towards, you know, providing medicine even to those people that they were insured or pensioners, but they could not afford their medical care, and they provide services to refugees and immigrants, and to any other service that were not covered by the public health care system. But in general, it was a moment of crisis. The opening again of the public welfare system was a moment of crisis for the solidarity clinics, also because of the political disillusionment and of the fatigue that they understood themselves kind of, they couldn't, many of those they couldn't, or to put it differently, those that they had developed only this anti-austerity discourse, in reality, they couldn't work out their role in the new situation, yeah, and they were not able to recognize the other elements that their practice has produced. So, but it was a strong element of it was also an experiment in reality of how people manage healthcare structures. Okay, so that went before, as many have said, went before the healing or before a restoring practice, but producing also a transformative practice. As two of the MIKIE, the largest Athens Solidarity Clinic in Athens said, I have two quotes here. The one it is that next to the free healthcare support and next to pressurize the government for public healthcare, for a decent public healthcare system, it was very aware for some people that they acted as a different model or example of social organization, and they didn't see themselves only as something that related only to health, but also in a way that other services, other infrastructure, the whole of the society could function and reform, let's say, yeah. And the second important element it is that what was different actually, and what made the difference in the solidarity clinics, it was not the medical practice itself, but it was the way that people were welcomed, let's say, and the way that people conducted the volunteers, you know, or they were were accepted by the volunteers of the solidarity clinics. This is important to see how it was reflected on the actual structure of the solidarity clinic. The most important, the most spacious, and the most busy, let's say, space of the solidarity clinic, it was the admissions. It was the reception, yeah? It was not the individual rooms where the doctors were receiving their patients. And also it was the space that actually connected the medical practice with the social aspect of a patient's life. One example, Pantxo mentioned something similar. Okay, one example is that, for example, when a doctor was saying to someone that, this is a real example, it was a guy there went and said, you have to take 3 pills after food every day. And the guy said, yes, but I know I eat only once in a day. Yeah, so it is how, because of this form of organization, the actual social life entered as an element in the organizing of health care. For that reason, the solidarity clinics were also connected with other solidarity structures to meet also these needs of the people, and this was an extension of the healthcare, let's say, the healthcare approach, yeah. And as another activist of MIKIE said, here what we produce is that we don't cope with the symptom, with the disease, but we cope with the patient as a social being. So it is a shift actually in the aim of providing medicine, and which is not affected the actual exam process, the actual practice of medical, but also it informed, you know, how a different approach, a more socially aware approach, more socially integrated approach, you know, to medical and healthcare treatment. Yeah. So this is this was through this experience, the solidarity clinics, they started organically to develop a different alternative or a counter practice, let's say, of medical practice. While they started from covering a need, they start also to develop a more holistic, a more rounded, let's say socially rounded approach to medical practice, and to reintegrate the health practice to its social context. So for that reason, I believe that, you know, they performed an integrative function in the sense that they integrated the social life and the community with the healthcare provision to the social life and the community. They challenge also, because they operated as a spaces of political participation, as a social, they developed social relation, a new social fabric of community fabric, but also as they had an economy, their own economy, health economy kind of healthcare economy circuit. They challenge this split between the different aspects of social operations, let's say, of either of the welfare provision of the modern capitalist state, and they had a combined restoring and interweaving operation of they restored and interweaved relations between all these different levels. Therefore, they had an infrastructural operation in many different levels, let's say. Yeah. Now, this is as far as how the main elements through which, let's say, this practice and this this priority, the primacy they gave to the develop primary kind of local primary healthcare services instead of structures, instead of big hospitalized structures, which became very apparent now in the debate about the COVID situation. The critique that the solidarity clinics do to, one of the critiques that they do to the solidarity, to the how the government has countered COVID, it is that everyone goes to, it is centralized to the hospitals, and the primary health care actually staff were taken to support these centers, these big centers in the hospitals, will create worse conditions, you know, for the patients, instead of spreading out, you know, and creating more primacy, more closer to the communities, more primary and more close to the communities' health care. Which is interesting that you can see the different structures of health care provision that can exist, or the solidarity clinics propose. So this is about the solidarity clinics. I don't know what is the, okay. I will go very quick on that, and because I think that it is another element of commoning elements, at least, of healthcare, and especially of medical care, which helps us understand, you know, the issue of commons, of urban commons and commoning somehow differently, not as using existing urban resources or fields or whatever spaces, but of creating kind of urban commons. The example that I will use it is the solidarity pharmacies. Actually, it regards an operation which the most successful operation of the whole of the solidarity movement. It is the collection and the reuse of medicines that existed, you know, that each of us had in their fridge, let's say, but not only. So this has been an immense operation that started as very small, a very kind of very practical idea in order to find medicine, but it developed to cover the needs of the solidarity clinics and of those that they were visiting there, but it was spread out and were developed in a huge in a network, of between the solidarity clinics, and with a huge kind of that engaged, many other people. So we have, as you see, in the donations, in the supply side, we have, the individuals, the citizens, the collection boxes in the local pharmacies, donation by other solidarity structures, corporate responsibility donations, and also provisions or exchange within the solidarity clinics networks. Yeah. So it is interesting to see the different bodies or parts of the sectors of the community, of the society, that are included in there, and how the solidarity structures, the solidarity clinics, actually they work as they operate a resource pooling kind of, or they are as a resource pooling hubs, and manage these resources. So in the middle, it is how they treat these donations, and then how they distribute. Oh, sorry, how they distribute them. Okay, and it goes towards the individual users that visit the solidarity clinic. It goes to refugee camps and other solidarity structures, but also to NGOs and public hospitals. Maybe now is happening less, or it's not happening, but during the crisis, it was very often that public hospitals were taking medical provisions, from the solidarity clinics. And also the solidarity clinics, they have organized international campaigns in Kobani, in Gaza Strip, and elsewhere. Yeah. So this is the numbers of those involved in the Metropolitan Clinic of Elliniko, where I know best and have data. The important it is to see how many, the number it is, this was between 2011 and 2018. It was about 7,500 people that the donors. It was over 30,000 people. 7,500 people were profited by them, but also it was the medicine that provided to users was 480,000 items, boxes, and to institutions and other networks, 900,000. So we don't speak about some small scale operation. And it is one, of course, the biggest, but it is only one of the solidarity clinics. And the reason I put this emphasis to quantities instead of qualities, it is because we have to answer if this is feasible to operate, and if we can, and to find ways how we can integrate it in the public healthcare system that exists now. Okay, and here it is the importance of common, because on one end, what they do. On one hand, what they do it is that they rediscover, they re-enter in the circulation as use value and not as exchange value this medicine. Okay, and by doing this practice, it has been observed in the interviews I conducted with people there, that the users of the solidarity clinics, even if they had not the same themselves extra medicines to give back, they collected medicines from their siblings or their neighbors, in order to give back to the solidarity clinic. So there, what was shared, it was not only the medicine, but was shared the practice. And this practice created a relationship that in reality, instead of public good that demands medical care because I'm citizen and because I have paid my taxes, okay, you had another kind of culture that was developed, that I want, because I cover my need through this structure, I want to support and give something back. So it creates us through this practice of solidarity. And this is why it was the importance of moneyless and of giving donations or giving something back in kind, either in participation or in medicine or whatever, And this creates a mentality of commons, and this is the practice of commoning in very simple terms, without with those people that operated knowing nothing about all the discourses of commons, yeah? And I think it is important for us activists or academics or whatever to find this kind of practices that I don't know if they are how much not revolutionary, but how much disobedient are or not. But in reality, actually, the fact that they are not disobedient, it's a kind of it is a how to say not a it is an additional kind of quality. It makes it easier for people to do it and participate, and how these practices actually they create the conditions and the challenge for us to articulate them in political forms and in institutional, let's say, forms. So I will stop here. Okay, I think I left many things probably out. Okay, but we have the room, you know, to deal with them in the discussion. Thank you.
Thank you, Christos. And thank you, Pantxo, also from before, again, just to bring you back in our conversation. I think now myself and Tommy will invite everyone else who is present to participate in our conversation if there are questions, but also just reflections, really. That would be great to hear, and just maybe bounce off what people are picking up from your talks. I myself, I have quite a few queuing up, so perhaps a good way could be to share to break the ice. I could maybe start, or maybe not, because sorry, I have a very small child who is now determined to participate. And there you go. Say hello to everyone. Hello. Tommy. Tommy, yes. Okay. I'll be with you in a moment. Okay. Okay, or maybe Tommy, you can take over and I'll join with my question in a second. This is partisan care 101.
Maybe I would like to broach a question that was also asked in Facebook chats about how the system of mental health care provision is organized in Trieste. An interesting aspect of both presentations were the maps, and the question of the territory and social distribution of needs, which is very specific. When we think about universal healthcare provision, there is an abstraction to that system that abstracts away from social structure, class structure, included and excluded structure, migrant population versus local population. And it would be interesting to hear maybe, Pantxo, how the system is organized in more detail in Trieste, but also if both of you could address the question of the territory as a dimension of organizing that sometimes also creates a problem. Very frequently, things are organized close where there is intense sociability, but the need is not necessarily there where that intense sociability takes place. I mean, you must be familiar with that, like where social movements convene and things like that. So maybe, Pantxo, if you can go first.
Well, if I understand the question is how it is organized, the social in the territory, the Trieste healthcare system, and what is the link of the fragility and illness of the person to the complexity of their life, something like that?
Yeah, Christos spoke about patients being social beings, and there's that dimension in the organization of psychosocial care in Trieste. So maybe if you can just go a little bit into the detail of that. You showed us the map, but maybe map is the territory there. So maybe if you can just delve into it a little bit.
Yeah. I think that's something that was resonating a lot to me of what Christos was saying, like the terms of Basaglia said in 60 something that the question was to put the illness in parentheses and think about the person and what is the process of emancipation rather than that of recovery, that you can deal with the sufferance and the illness only when you have dealt when you are also dealing with the dimension of that social life. So one technical answer and one more political answer, if you want. The technical answer is I can tell you a little bit about what is the organization of mental health care here in Trieste, in which you don't have a psychiatric hospital. Just to mention to you, like we're discussing with Tommy, what is the situation in Zagreb, and I suppose many of the people that is listening is from Zagreb or not, but maybe Zagreb is a good reference point. In Zagreb, you have two big psychiatric hospital and a psychiatric hospital for minors, and they end up having like more than 1,000 we calculated inmates, people in
13, they have 1,300 beds, not necessarily, there's many empty beds, but
yeah.
In a way, structure is organized around beds, the capacity of healthcare, psychosocial health provision is organized around beds for reasons of path dependency, but also the way psychiatry is conceived of. Whereas in Trieste, it's only 30 beds. No, correct me if I'm wrong.
Yeah. And I think that's interesting in the terms that these 30 beds are in 5 different locations. They are in the neighborhoods. So there are services that are open 24 hours a day, 365 days per year, and they're always open, and they are always now the situation is a bit more complicated because of COVID and because of a crisis of the system here. But you have like on the one hand a very reduced possibility of hospital care, of hospital-like care, like even the small centers in the neighborhood, they can become small psychiatric hospital if you don't have a connection with the territory. And then you have another number of levels of interaction, which are the social cooperatives of labor integration, inclusion, or participation. You have laboratories of artistic practices. You have a number of systems of assistance and support. So for us to give you a sense, if it's true that you have not 300 but 30 beds, you also have most of the money that's been saved by not using it to support beds is invested in home assistance, labor inclusion, the support to social cooperatives, and so on. So you have a social cooperative movement that only in Trieste counts for 1,000 people occupied and around 10-15 millions per year of production, which can be my cooperative, which make communication and hospitality, bars and restaurants. We can be a tailor shop as we have on the other side of the same building, as can be other kind of cooperatives, gardenings, and so on. So the idea of producing a disorganization and reorganization to play with the raison d'être of public budget in order to sustain other possibilities. And I think here a term come and is important to me. If you may know Marmot conception of social determinants of health, no? So Sir Marmot says, and the statistics support him in saying that almost the 60% of diseases are determined by social determinants, housing conditions, labor condition, etc., etc., etc. My feeling is that in Trieste, my understanding, my analysis is that in Trieste, there has been something more than understanding that there is social determinants of health. The point has been to say that there are political determinants of the right to health. So that health is a right, and if you constitute it as a collective right, you have to produce and understand what are the political determinants of it. The fact that you have a shit house or don't have a shit house is obviously a social determinant of your health, but the fact that you have a right to have a house is a political determinant of the fact that you have housing rights or not. I was talking a week ago, we were doing an interview with Giovanna Del Giudice, which was one of the first psychiatrists to come here. And she was telling to me an amazing story of when they opened the first center for mental health care in one neighborhood where there is an important cartiera, paper factory, a factory that produces paper. And they, after having a strong relationship with the union inside the factory, they organized in order of two people that was in a very severe fragility to start to work in the factory. And after a few months, one of the union guy came saying, "Okay, we cannot really deal with this guy anymore. You have to help us because we are in difficulties, and the owner is in difficulties with it." And the guy was passionate because the instrument that they used to put down the trunks in the water in order the trunks to fill with water and go deep in water, and then you can make paper. He was saying, this instrument is shit. I cannot use this instrument to put this down because the volt is too low, whatever. And what was interesting, and Giovanna was saying that when they came there and they started to discuss about it with him and then with all the workers, the thing that was is a crisis of the madness. After a few hours of talking and relaxing him down, became a worker demand in order to ameliorate the condition of their labor. And I think that here it's very clear how this relationship with the territory is not just an organization of the territory, as I was trying to briefly explain to you, but also is a political determinant of the right to health. And this is the two ways around. It's not just for the one that is for the loony, but it's for society. And I think that one of the principles that is important here in Trieste is that it's not about taking care of the psychiatric problem of one person, but is about taking care of the mental health of a territory, which I think makes this story kind of more clear.
Absolutely, and that's as you were saying, it's a matter of gradients, and the next, I think. One of the things that is coming out very strongly in many ways is that healthcare is some kind of it needs to be a byproduct of very different politics, kind of producing the conditions for healthcare for health or wellness to appear and be socially redistributed. I have a question.
For care to be supported, like that, I think that is a matter in which many policies can contribute to health and wellness. But the point is how policies can support the collective practice of care, which I think is always an ambivalent word, care, because it's also a word of discrimination, exploitation in the families and in the, so it's not a buzzword, but it's not
Yes,
just about.
absolutely. And the same is, we can say, for health, but at the same time, I think they are political terms precisely because they're so spacious that you can get lost in them, but we have to rework them. And there is this definition by David Harvey, who is a geographer, who says that it's quite scary that one of the most operational definitions of health in our societies is, of being sick, is the inability to work. And I think this in itself like defines a lot of kind of reveals a lot of the unconscious that we deal with. Anyway, there would be so much to say, but I do have a question for Christos coming from Zoe. Who writes in Facebook, thanks for the presentation. I was wondering if in Greece there was a setup of any digital infrastructure, for example, with barcode readers or digital databases, while for the handling, like the coordination of the commoning, stocking of medicines, and what's the role? I guess she's asking about open technologies per se, but I think maybe the question can be read as a broader question around the role of technology and technologically related knowledges in the composition of the clinics and the pharmacies.
Yeah, and I think also it relates, with the issue of territory, because we have to also to get in the digital kind of space now. First of all, it has been a platform that support that people can use, to donate or to receive medicine. Yeah, and also. There have been efforts, I know it because I was involved in these efforts, to create to create such a tool for the solidarity clinics, but they did not want to have. Individually, they are in contact with this other platform that exists, which works also for NGOs and other different for anyone. Yeah, it's open to anyone. The reason they didn't want it to have it, it is and to connect it digitally their stocks and to manage their stocks and etc. It is because there were actually two reasons. One, it was the new technologies, and they didn't understand them, and they thought that they won't have a control over them. Yeah. The second, so it was an issue of trust, really. One. The second, it was that their emphasis. What they said is that we don't want to be to depersonalize the conduct, we do the conduct of the solidarity practice. We want people to make the effort to bring the medicine here, to meet them and see what we can do with together with them. And this is interesting. If you see from the point of view of network society, how this movement operates. In reality, it reflects the logics of the network society in the physical space, but it does it manually. Okay, which is very interesting that it does manually, because it develops, different kind of intelligence and different kind of relationships between people, rather than taking part the issue of services or information or skills or whatever, decontextualize it from the social aspect, and not the social, but the relational aspect that it has, that is involves, the human conduct, let's say. And it is interesting to see how this also informed, the few solidarity attempts during the COVID situation, that in reality they played out between these two spaces. They were organizing digitally the information and the collection of resources or ideas, etc. But it was organized in a very local level with a kind of personal conduct, let's say. So I would say that although we need to do more work on that to see the phygital dimensions of the solidarity clinics and how they use the digital world, the digital media, let's say, or the social media, in order to meet their needs and to enhance their kind of social their social work. I'll put it this, or the social intervention. I'll put it this way. In reality, this hasn't caused the solidarity clinics because the solidarity clinics themselves, they had a specific list that they communicated through this in order to meet their own needs. Yeah, and what they didn't do, it is that they didn't atomize the issue of of solidarity, of exchange of medicine or medicine reuse, let's say, in that case. In this way, what they did is they worked they used the peer-to-peer logic, but in a collective way, in a collective context, not in a context of people, person with person. Okay, but it was the same logic, let's say, behind it. So I said that instead of platform capitalism and platform cooperatives and all this logic that exists in this, even regardless open or closed source, in reality, what they practice, it is a sense of open cooperativism, which means that I don't donate. It's not only myself to find a solution, or only myself to do it for my good. Okay, even if collectively, but I do it for the good for the collective, not of the collective that I belong to, but of the larger collective, of someone that I don't know. And this issue of the solidarity to the stranger, it is important, to those that I don't know. Okay, and how the solidarity clinics operate and kind of have this kind of work as this kind of infrastructure. Now, another thing that I want to say for the territory, it is that regarding the map, it is an interesting example that not for the solidarity clinics, but for the it is to see where the cooperatives, where the workers' cooperatives were more populated, let's say. It was were situated. It was in the center of Athens with people from so it was not in working class areas. It was in the center of Athens. It was on the service sector by people with high cultural and educational capital. While in the poorer areas, you don't have many workers' cooperatives. Yeah, you have many food solidarity structures. The the solidarity clinics are more evenly distributed in different areas. But there is a difference according to the territory in which they operate. For example, the solidarity clinic in Athens was used mainly by transit people, by people in transit, like immigrant communities, immigrants, refugees mainly. And it was much more difficult to engage those people, to engage the users in the actual running of the clinic, and to develop a community around it, a larger community around it. While in other cases where it was made by people better integrated in the local region, let's say, it was easier to develop this community and the people there to understand it as their solidarity clinic, even in territorial terms. Yeah, and interestingly, the issue of the Metropolitan Clinic of Elliniko. Elliniko is the outskirts where the old airport of Athens was, but it's called Metropolitan because the initial idea it is to cover the needs of the old metropolitan area. But most importantly, because it was located in a space, in a disputed space, under privatization of the old airport, and was part of recuperating this space and making it with the municipality's support, and turn it into a public park that will host also other kind of cooperatives and commons. It was also a cooperative farm and other things there too. So territories are very, the territorial aspect is very important, but also as I described, it was the different territories in which these territorial scales within which the solidarity clinics have operated. Okay.
Super, thank you, Christos. I may take the chance to ask the question that I was hoping to share earlier. And it's really for both of you. And it's very simple, if you like, but I think from my perspective, quite pressing. And it is, it revolves, I'm not even sure how to ask this, but it revolves around, from the histories that you presented, more or less recent, but what are the most important components that lead to the politicization of a critical mass of professionals that seem to, and what is your take around this question of the expert within contemporary social movements? I know it's a very broad question, maybe we can take it in different directions for sure, but for me, what's very powerful hearing the stories and the components and the capacity really to scale of the radical psychiatry movement in Italy. It's really the diversity of actors that it involved and the capacity to act, care at the level of legislative reform and medical praxis and social service modeling and designing and. No? So it's super interesting kind of generative experience, and it involves very crucially very specific knowledges at each of these nodal moments to obtain this deep kind of, you called it a substitution of one system with another, which is a very powerful way of putting it. And in the case of Christos, of the material you were covering tonight, it seems to me incredible, because this is people that are contemporary to us, the historical moment and the crisis moment and the austerity moment we all lived through. And yet these volunteers who are doctors in Greece, they come from a very, from what I hear, problematic kind of class of experts, because the medical class of Greek doctors is not an easy interlocutor for a lot of reforms. And this has been the case, actually, looking at the history of public healthcare in many countries. The medical classes are tough to crack and often have been actually standing in the way against reforms of healthcare that would lead to more equitable and just reformation. So I'm very compelled to ask in this direction. I'm not sure if it's the best way to frame it is expertise. Maybe it is not. Maybe it is something else you might think about, subjectivation. But if you have any thoughts about what's there for you, what can we look for or try to organize around, what are the most difficult aspects of the stories? Thank you.
May I start? Yeah. Okay. No, it's. I think it's very concrete what you asked. At least in the experience of the solidarity clinics. Yeah. This was something that I didn't say, but the fact is that the majority of the doctors that participated Actually, they participated by offering services and not taking part in the assemblies and the organizing of the whole thing. Yeah. So this has got many readings. One, it shows, as you said, how strong is this mentality of the medical caste, as you said it in Greece, and the hierarchies that exist and they're reproduced by the established healthcare organization, yeah, and the medical system. The other is that, but on the other hand, it shows that doctors and specialists are not needed necessarily in order to run efficiently, and successfully community-based and run healthcare infrastructure. And I think if we want to find, some prefigurative elements, it is there. Instead of, in case of when we think about what kind of different kind of healthcare institutions we need. So it's not that much about politicizing the doctors or what they do. This is one aspect that can produce critical medical practices and alternative medical care, but these cannot be produced, because of the politicization of doctors, but it is affected, their practice is affected by the social context in which it takes place. So in that case, it doesn't matter really, it is how you create a context or the material and the social conditions within which this specific specialty will re-articulate itself accordingly to the needs of the specialist. This is why I was saying that it is not the solidarity movement. It didn't start because it wanted the solidarity clinic. Sorry, they didn't start because they wanted to build an alternative to, or to propose an alternative method or healthcare system. It was the opposite. That the social conditions and context informed and led to developing critical thoughts, ideas, practices on health care. And also the doctors were motivated and participated from different kinds of motives. Okay, they just wanted to help. They saw the unjust. They couldn't function as they wanted within the public healthcare system, and they wanted to give out of good heart. Most of them, really, something to help out a situation and a very kind of intense politically and socially situation that Greece went through in between 2010 and 2015, let's say, or 16. Yeah, so I think again, what politicized the doctors, or what made them kind of take a position, take a side, and or being active. It was the general atmosphere in the society and the possibilities that were created for a change. Yeah.
Thank you. Yeah.
No, I think that also in Trieste is a matter of the general the atmosphere, the atmosphere of a period. We are talking about the 70s when this took its major force, and you have to consider that compared to the rest of medicine, which and we know in the pandemic very well, like there are artifacts and a lot of ambiguities and ambivalences, but there are also artifacts. But psychiatry is the most feeble, the most weak of epistemologies of any kind of illness. It doesn't exist as a science out of power. The only thing that exists there is power, no? So in a sense, the fact in Trieste was that there was a social movement against power. There was all over in in Italy and probably in the world in that moment, but also a generation of militants that by chance were also doctors that were thinking their work politically, what was ethically and politically, what was we were today. It's very interesting because here of that generation of the 70s, everybody comes here, everybody is not dead, comes here every day to talk and discuss and think through the documents and through what is happening today. They are militants. They are still militants, and so that's very, very strong. So I think also the question is, what is the problem today in which how we make expertise to become a more militant practice today. I was watching in these weeks and months again a number of documentaries about ACT UP. I think that to look at ACT UP in these 2 years has been one of the things that allowed me to find an orientation through what was happening with the pandemic. ACT UP, the movement of organization of people with AIDS in the 80s and in the early 90s, and the way in which they reappropriated a number of knowledges in order to produce a political relationship with expertise, with experts, I mean with doctors and scientists in that case, but also with knowledge is fundamental to me. And I think that this is something very common between Trieste and the Greek experience of the last 10 years, the way in which you produce a social political relationship with workers, and this social political relationship moves things. Is not, as Christo was saying now, no, it's not a matter of politicizing them. It's a matter of making clear the political context in which their practice is involved, that produces a shift, an involvement, etc. Second, how we think a social knowledge of care, a social knowledge of health, as you were saying before, Valeria. So both of these questions, ciao, and both of these questions put us in the present in a very complex way, I think. So the question is how we deal with knowledge and experts in the moment in which the COVID pandemic crisis, in the social sense, put us in a sense in which there is a strong authoritarian shift or turn of political power, but also an individualist and self-centered shift of rebellion, no? Like in Trieste, we had 15,000 people in Novax movements in a city of 200,000. So we have 1/3 of people with no vaccination. We cannot polarize this dimension. We have to find ways of breaking this micro-political fascism that enters in the people. But this is very difficult to do because on the one hand, we don't have a possibility of discussing of knowledge in a way that is materialistic. And on the other hand, we have to destroy the separation of experts and expertise from the social complexity of life, in which there is fear, in which there is difficulties, in which there is a number of things that you cannot just answer by saying you need to obey to the state. That doesn't work for many reasons, but it doesn't work, so we cannot just repeat that. So I think that this question is very open today, but there's no, I don't know the solution. We don't know the solution. We have to look for it together.
When we were putting together this seminar, obviously was what motivated us to organize something in healthcare as disobedience is thinking from the present moment. As there is, it's hard to say it's an opening. It's a cleft, a void that was opened by the pandemic. It showed a radical lack of social capacity to provide for various aspects of sustenance and welfare of people. And what we were interested in is looking at historical examples where radicalization in healthcare and provision from below transformed medical and healthcare systems, which usually function in a very organized, top-down, governed fashion. So maybe we should wrap on this note, as now it's 8 o'clock. Tomorrow we'll have a session that will again go back into history, and it will look at exactly the radicalization of medical professionals in the Second World War that have built sort of parallel medical system in the battle that carried over into the post-war period, building many of the expectations that of public healthcare provision that we live nowadays with, and that were developed during the period of socialist modernization. And we'll also look at the role of patients in organizing around patient rights, which frequently comes together with professionals and specific restructuring of knowledge related to medicine. During these days, we are scanning and digitizing an editorial series that was run by Giulio Macacaro, another figure, I guess, of Basaglian heft or importance for the Italian public healthcare system. And basically it's a series of books titled Medicine and Power that look at the exact political conditions of the production of knowledge in the profession, and the relation to patients as not being simply objects of medical knowledge and expertise, but being the fundament and sort of transformative force from within. So I would invite you to join us tomorrow. We'll again be on Zoom and Facebook Live. The links you'll find there where you found the links for today. So please do join us as we hear the talks of Sanja Horotincic and Maddalena Franito. Pantxo, Christos, thank you so much for your talks. That was really rich and delved into so many dimensions and with so much clarity. Yeah, thank you. And maybe with this, I don't know if Valeria wants to say the final word before we finish.
Thank you very much to you as well.
Thank you, everyone.
Thank you all.
Yeah. Okay, thank you for listening and being audience tonight. See you tomorrow.
Bye.